hepatologist being the prime person involved, because most of the liver transplant programs are hepatologist run. A few could be surgeon run, but you have the transplant surgeon involved, a transplant anesthetist, a nephrologist, an infectious disease consultant, and a psychiatrist in some cases. You would also have the transfusion medicine consultant and or a hematologist involved in the management, because at some point of time we would require their help, and probably in the post-op period after a liver transplant also we might be in consortium with them. There's also a possibility of having a nutritionist, because sarcopenia and has been probably this was a thing which was not looked into earlier times, but now much more looked into as for the nutritional deficiencies in these patients, which improves the outcome and decreases the waiting list mortality and morbidity. Hepatocellular carcinoma is one of the causes for which come up for a liver transplant. It is a third, because it's a third leading cause of cancer-related deaths worldwide, and cirrhosis by itself is a precancerous precancerous condition which predisposes to hepatocellular carcinoma. And nowadays there is a rising incidence due to genetic heterogeneity, multiple etiologies, and concurrent chronic liver disease. They're making the diagnosis and staging and selection of treatment options challenging. As I had previously said, that most of these cases follow a set type of guidelines, but could waver out of these. But there are the Barcelona clinics and the Milan criteria, which is usually followed, and also with close. So you need these patients coming in for a transplant. You need the liver board, liver tumor board, consisting of a hepatologist, a pathologist, interventional radiologist, the oncologist, and the hepatobiliary and the transplant surgeon, and intensivists and nurses. You need a physiotherapist also included in this group to build up these patients going in for a liver transplant. You have to, with the input of all these disciplinary disciplines, you are just trying to get the best way you can optimize a patient for a transplant. Many of these patients, they're decompensated, they come with renal dysfunction, acute kidney injury. As has already been mentioned in the previous talks, acute kidney injury occurs in about 50% of patients with decompensated cirrhosis, mainly due to impaired effective blood volume due to arterial dilatation and increased intrarenal vasoconstriction. You have splanchnic vasodilatation, and staging of, in the face of splanchnic vasodilatation, you have staging of acute kidney injury in cirrhotics is guided by serum creatinine and urine output. The AKIN guidelines and the KIDGO take serum creatinine and urine output, whereas the International Club of Ascites, which takes the AKIN guidelines without urine output. They take only the serum creatinine into consideration. Renal dysfunction, these recommendations, what I say is most of the speakers have already spoken about in many other organ dysfunctions. This has been published somewhere about in 2016. It was a consortium formed by the American Society of Transplantation, American Society of Transplant Surgeons, and the European Society of Study of Liver. They have endorsed some of the recommendations which most of them have already been validated. So they say replacement of the volume should be with a crystalloid, preferably with a balanced salt solution for fluid losses, and in blood in case of acute gastrointestinal bleed, vasoconstrictors, and albumin in suspected type 1 HRS for various reasons. Albumin, as already mentioned, albumin will help in these conditions. And you have guidelines with the nephrologist in consensus with the nephrologist. You can discontinue treatment depending on the creatinine level in response to treatment. So you either You take a baseline creatinine for the last 3 months and then treat them and then get them into the best possible shape. But patients who have already had an acute kidney injury are always at a risk of having having some renal impairment post liver transplant. There is a high possibility. Cardiopulmonary dysfunctions, to touch about it, is characterized by a high cardiac output, low SVR, a decreased oxygen extraction resulting in high cardiac output failure. This is more of a distributive shock condition. State of effective hypovolemia with sodium and water retention and spasmodic vasodilatation. They could present with portopulmonary hypertension, which is an imbalance between the vasodilatation and the vasoconstrictor parameters, where you have endothelin-1, which is very high in cirrhotic patients, compared to the nitric oxide, which is produced more in other areas, but in the pulmonary circulation, you have reduced nitric oxide compared to endothelin-1. And this year you have to treat them pretty aggressively because as previously, as I'll be mentioning, that there is a cutoff point for going for a liver transplant in patients with high pulmonary artery pressures. Hepatopulmonary syndrome is another one which comes with low saturations and fatigability and breathlessness. And these patients have to be treated quite aggressively because they do have VQ mismatch and decreased saturation. The portopulmonary hypertension patients also could end up with right heart failure. You might need the cardiologist for intervention cardiologist and the help of a pulmonologist. You try to maintain a pressure of more than 60 millimeters mercury. You don't go to very high levels with fluids with either balanced salt solution or isotonic saline. Your role of albumin in large volume paracentesis and spontaneous bacterial peritonitis, already mentioned their benefits. According to the consortium, noradrenaline is the first vasopressor of choice. Vasopressin or telepressin could be used. There are some cases where you use telepressin itself might be sufficient. A trial of steroids in refractory hypoxemia, refractory hypotension could be given a go. These patients are very prone for infection and the high risk of bacterial and fungal infections because of dysbiosis and bowel bacterial overgrowth. They might be immunocompromised and have resistant organisms. As already previously mentioned, ceftriaxone is usually the drug which is given for 7 days, which is following a gastrointestinal bleed. Primary spontaneous bacterial peritonitis prophylaxis usually being given with ascitic fluid less than 1.5 grams percent of protein. And secondary prophylaxis in patients with SBP with Norflox. But these patients could come up with resistant organisms. So you have to be careful when we are working up these patients for a transplant. Antifungal therapy, there are a set of guidelines which I'm not going into of where and when to start antifungal therapy. You have coagulation problems, as Dr. Arun has already given you a detailed thing, which is a discrepancy between the bleeding and the thrombosis. There is a problem with primary hemostasis with platelets, secondary hemostasis with coagulation profile, and fibrinolysis. We always tend to use point-of-care coagulation with TEG and ROTEM. As already mentioned, INR and PT are not very good indicators. Neurological dysfunction, they end up with hepatic encephalopathy, which overlaps concurrent infection or electrolyte imbalance. Brain imaging should be done, is indicated when it's abrupt and severe onset, or there's any local deficit, focal deficits, and if there's no response to treatment. EEG to rule out other causes of decreased mental status. The treatment is lactulose is the first line. We're monitoring electrolytes and ileus development. Rifaximin, you tend to put them on lactulose and rifaximin to reduce the incidence of recurrence. Albumin dialysis, plasmapheresis has been tried in many patients with high bilirubin and hepatic encephalopathy, but not been validated as such as now. LOLA, L-ornithine and L-aspartate have been used in showing variable results in workup of patients towards liver transplant. LOLA, there's one study, one highly regarded study of German study which said that they are beneficial. So what we'll go through the absolute contraindications for liver transplant is severe cardiac and pulmonary diseases. Severe pulmonary hypertension, usually mean arterial pressure is more than 45. You might need a right heart study and probably optimize these patients coming in for liver transplant. Alcohol de-addiction without motivation and abstinence or ongoing abuse of the substance. HCC with extrahepatic metastasis, those are all covered by the Milan's criteria, which with those patients to be taken up. And patients with severe sepsis are a contraindication. You have a relative contraindication, which is untreated alcohol abuse. There's a lot of debate about this. Cholangiocellular carcinoma, hepatic metastasis, endocrine tumors, morbid obesity, and persistent non-adherence. Many of these, the relative contraindications are pretty debatable. And we would like, many of the things have been brought up by the previous speakers. We have to optimize these patients, and you have a time frame. If they're coming for a DDLT, you keep them worked up for coming for a liver transplant. And if they are coming for LDLT, probably it's a much easier way that we have a shorter period of time working them up. Thank you very much.
Thank you, Dr. Kuttappa. That was a lucid presentation. Now I request Dr. Venkatramana to talk on basics of transplant immunology.
Good morning. I first of all thank the South Zone Vizag team in inviting me to this wonderful scientific content. Coming back to my talk, basics of transplant immunology. Either I am an immunologist or I work in a transplant as a transplant intensivist. But just because it is a basics and it's a 14-minute talk, I just took over it. So let us see what we can learn about it. Graft and transplant is nothing but a transfer of a living cell or a tissue or organ from one part of the body to other or one individual to the other. We have many solid organ transplants. Literally every organ is transplanted other than brain. We have hematopoietic stem cell transplant. We have also grafting of many tissues. Literally all the parts of the body has been grafted and been secured also. We know there are many kind of grafting happens. Autografting when the same organism from one part to the other. Allografting from the same species, and if genografting from the other. We know isografting or acinografting when identical twins transplant from one to other. Coming back to the transplant immunology's basic. The immune response always behaves or identifies this any grafting tissue as a foreign body, and it has an immune response to this. And this has been majorly contributed by a allele gene component complex that's called major histocompatibility complex. It's called major because it is the major chunk of the whole immune response happens to this foreign. So this set of gene alleles are generally found in the shorter arm of the chromosome 6. And this creates a HLA, human leukocyte antigen protein, glycoproteins. These are present in many cells. Almost all nucleated cells for the class 1 and few polymorphs in the class 2. So this HLA system is a very polymorphic genetic system in humans, and this has successfully enabled population to survive infectious disease, but it restricts the ability of transplant a foreign tissue into you. So this is a glycoprotein. It creates a glycoprotein on the surface of cell, which helps in antigen recognition and presentation. The HLA, human leukocyte antigen, is a predominant one which we will discuss about. There are two classes of it, class 1 and class 2. The class 1 is expressed in all the surfaces of most of the nucleated cells other than RBCs. Class 2 on many of the lymphoid antigen presenting cells. The class 1 has ABC and class 2 has DR, DB and DQ variants. And this is the HLA typing which we do before a transplant. And now we do a phenotyping. When I am inquiring with my transplant team, they do a phenotyping, and some of them are now starting doing a genotyping with PCR-based sequencing. So this kind of the major histocompatibility molecules, that is a HLA antigen, which is a glycoprotein, is present in many of the cells by a covalent bond to this cell wall. And this HLA2, that is the second part, which is present in many of the major antigen presenting cells. And this is not present in the RBC. The class 1 is not present in the RBC. That's why the HLA typing or HLA will be not a major component when we talk about hematopoietic transplantations. So the two types of cells, the B and T, represents or they react differently to this kind of things. The T recognizes an antigen only by a peptide, which we'll see. Peptide, which combines with this major histocompatibility complex, but the B directly gets in touch with this antigen on the B cell receptor. This is how actually the T cell combines with this peptide recognized by this any of the cell where this major histocompatibility complex or HLA is there. And this, when it is a self, they will be normal. When it is a foreign, they react to that. In the same way, the APC, antigen presenting cell, which actually contains this major histocompatibility class 2, that is HLA2, reacts in a different way where there will be no peptide in between and it directly reacts. There are some non-professional antigen presenting cells other than the polymorphs. They are the dendritic cell, microglial cells, fibroblast, elastic fibers and all this. And how they present any antigen is on their cell surface, they react to that by a type 2 variant. The goal of every transplant is to avoid an immune response. And this immune response generally happens with allogenic and genoic transplantation types. There are two types of ways how a body responds. The first variant here, where the allogenic APC in the graft, the antigen presenting cell in the graft, which you have grafted or transplanted in the tissue or the organ, presents this MCH to the alloreactive T cells. That is kind of a direct allo antigen recognition. The graft APC, antigen presenting cell, presenting the major histocompatibility complex to alloreactive cell. The other side, indirect one, where the allogenic MCH has been read by your antigen presenting cell of the recipient or recipient, and that recipient antigen presenting cell again present to that to alloreactive T cell. To oversimplify it, direct presentation is a donor antigen presenting cell, major histocompatibility comes in contact with your alloreactive T cell, whereas in indirect, the recipient antigen presenting cell comes in contact with the donor peptide. Often a transplant organ is not identified by the immune system as its own, and it is attacked and destroyed. So you need a kind of immunosuppressants in many of them to give a immunosuppression somewhere like an acquired immunodeficiency syndrome kind of a phenomenon. It can actually destroy the organ in 15 to 20 minutes also. So this is all about HLA component, which we are talking about, the major immunohistocompatibility system. The other immunology which plays an important role in transplant is ABO incompatibility. ABO compatibility is also been important. As we know, any blood transfusion also need ABO incompatibility because the antibodies are expressed if you transplant or a graft a tissue without any ABO incompatibility. That can bind to the antigen on the vascular endothelium and can cause a hyperactive reaction. We know O as a universal donor and ABO as an universal acceptor. So AB compatibility or ABO compatibility before we go into the transplant is again a norm. But nowadays we are seeing that even A can transplant to B and all that happening. We know when we wanted a donor to be given to a B recipient, the B recipient will have a NTA. So this NTA has been taken out by a plasma exchange or a plasmapheresis, and NTA has been dropped down to below 10-15%, and then transplant occurs, and this continues, this exchange or this plasma exchange or plasmapheresis has been continued for few. We have a case series of 6 or 7 in the recent times. So there are also, if suppose you have identical twins which actually has a transplantation, there also we see some kind of rejections, and these are a minor histocompatibility antigens mediated, which we do not test many of the times. So how actually a transplant immunology or this transplanted organ gets hit? One is by cytotoxicity or delayed sensitivity reaction or antibody-mediated reaction. So if we see a hyperacute reaction, this happens by a preformed antibody. There is an antibody because of an exposure, and this preformed antibody can cause a destruction within minutes to hours. The oven will go into a rejection. The commonly seen is when you have some sensitization. How do this sensitization happen? By a form of blood transfusion, pregnancy, or a previous transplant of some forms. This gives a pre-sensitization and preformed antibodies which can rapidly, within minutes to hours, destroys the whole phenomenon. Acute rejection happens more through a cellular mechanism, the T-cell mediated mechanisms, which actually develops to the days to weeks of the transplant. Then this chronic process happens to the months to the years, where a progressive atherosclerosis causing a progressive fibrosis and scarring of the vessels, lumens, and that leading to this kind of, majority of the times these are all happens because of the minor histocompatibility complex, not the major one. This is a pictorial diagram of how actually this allograft rejection happens. When a transplanted organ got hit by the antigen presenting cell moves to the lymphoid organ, and this triggers T cells, secondary lymphoid organs, to create a helper T cell and helps the B cell to make alloantibodies. These alloantibodies and effector T cells create an inflamed state with CD4 and CD8 cells, causing the different organ injuries in the form of interstitial macrophage infiltration, intimal arthritis, tubulitis, and different form of injuries which can cause the allograft rejection. So there are many immunosuppressions which are used. We will not go into details, but glucocorticoids, antimetabolites, probably the calcineurin inhibitors, and monoclonal or polyclonal antibodies have been used as an immunosuppressant in different formulations and combination. There are different sites where they work, from T cell on the tacrolimus or cyclosporin, and antimetabolites on the other side. So this is how the immunosuppression attacks. Lastly, we have now only known about the T cell of the recipient causing the problem after recognizing the major histoincompatibility with the transplant or a graft tissue. Now sometimes the graft tissue's T cell, suppose there is a mature T cell in the graft tissue, grafted tissue, starts attacking the host recipient organs. Most commonly what happens, it attacks the skin, gut, and liver, and that creates a graft versus host disease. Major problem is hematopoietic stem cells transplantation, not in the general organs, and this is actually can be prevented by bone marrow to deplete the T cells, or use probably autologous bone marrow, or sometimes umbilical cord blood. So take home for this is immune response identifies the graft and the graft or a transplanted tissue as a foreign. It will try to actually push it out and take it out. And the donor, when we actually discuss with our transplant team, the donor lymphocytes are first mixed with the serum of the recipient antibodies to pick up any preformed antibodies. Suppose the donor's lymphocytes are combined with my recipient sera, and it gives you some kind of a reactiveness with an antibody. That means there is a preformed antibody. That is the first point which will they pick up, whether there are preformed antibodies or not. Then they actually ask for a HLA matching or major histocompatibility matching between the donor and recipient, and they compare between the class 1 and class 2 variants, what are the match. And now if the match is perfect, which happens in many of the kind of the identical twins, that is very good. If the match is not perfect, they need to know what is the match percentage, and accordingly they have to decide on the amount of immunosuppression this patient is going to take. Majority of the time this doesn't decide whether the patient will go for transplant or not. They have to go for a transplant in verse of what we have. But this will decide the amount of immunosuppression this patient will need. Again, to ABO incompatibility or compatibility, we know that blood grouping matching is required. We know which can take what. O as a universal donor and ABO as a universal recipient. But yes, we now started doing also cross A to B and B to A. But in those situations, we need to take out those antibodies from in the form of either a plasma exchange or the plasmapheresis before you transplant, and keep on doing it for a week or two. And HLA sensitization need to be kept in mind. Females receiving blood, having a pregnancy or some form of tissue grafting in the skin or somewhere hair transplant need to be kept in mind, because this can have a preformed antibodies which can cause an acute rejection. And graft versus host disease, where graft's own T cell can attack the recipient's immune system, recipient's organ, and cause problem. Immunosuppression, yes, this will be a phenomenon how we are now upgraded ourselves with of a newer, invented, advanced immunosuppressants, which will take us a better way of controlling this immune response. This, I thank all of you, and this is my team.
Thank you, Dr. Venkatramana. That's a very nice presentation. Now I request Dr. Sriram Sampath to talk on physiology of reperfusion injury.
Good morning. I am going to be speaking more on the pathophysiology of ischemia reperfusion injury. Now, these consequences of ischemia everybody knows. Whether you have a stroke in the brain or whether you have a myocardial infarction, it's well known that if you restore perfusion, the infarct size may increase. This has been well known for many years and it has a very long history. As far as cardiology is concerned, the benefits of reperfusion are more than the risks, but the infarct size can increase. Now, the question that was bothering the physiologists was, is this due to lack of blood flow, or is it due to reintroduction of oxygen when the blood flow starts? Being physiologists, they will always have many hypotheses. So, what did they do? You take a small animal, clamp the bowel for 4 hours. Then another animal, 3 hours of ischemia and 1 hour you reperfuse. Another animal, 3 hours of ischemia and 1 hour of deoxygenated reperfusion. And what did they find? Maximum necrosis is with 3 hours of ischemia and 1 hour of reperfusion. So, restoring blood flow and restoring oxygen, our ABCD of intensive care may actually increase infarct size. So, this is your ischemia reperfusion syndrome. So, this has been well recognized for many, many years. And what is the biochemical mechanism? This has been well studied for many, many years. In 1980, xanthine oxidase started coming in the journals. And why xanthine oxidase? Because basically life is dependent on ATP. And when you cut off the oxygen, the xanthine oxidase can become xanthine dehydrogenase and vice versa. And this can cause a lot of injury with many mechanisms which have been mentioned. Now, where does this ischemia reperfusion thing happen? Does it happen at the local level or does it happen at the organismal level? Now, suppose you produce ischemia and the cell quietly shrinks and the contents of the cell are nicely recycled and there is no wastage, there is no inflammation, there is no release of enzymes. This is apoptosis. Suppose you get ischemia and you get a lot of inflammations, you get ARDS and all that, that is necrosis. So, this reperfusion of ischemic tissues often causes necrosis. And peculiarly, this apoptosis necrosis is described in scientific conference audiences also. After the first 2 slides, if you go to sleep, apoptosis. After the first 2 slides, you go to the coffee table and say useless speaker, that is necrosis. So, what is the mechanism of this? Mechanism again, it is again through the mitochondria. So, you have ischemia, your mitochondria don't work, your pumps don't work, your sodium potassium pump doesn't work. The moment your sodium potassium pump doesn't work, the environment inside the cell, the environment outside the cell equalizes. Your cell will swell up, it will necrose and die, and whatever is the content inside the cell is going to go outside and it is going to cause a lot of damage. So when you re-establish blood supply, we in intensive care think we are restoring oxygen, we are restoring circulation, we are restoring the blood pressure. What also happens is all the waste that is accumulating inside the cells is also going to get flushed out, and that is going to produce some deleterious effects, which is probably your ischemia reperfusion syndrome. Suppose a ischemic limb is reperfused. The venous blood often has a pH of less than 7.2. And what is the cardiac arrest due to? Most probably it's a hyperkalemia from the potassium which is leaked out of the cells. This is probably the reason you get acute kidney injury due to rhabdomyolysis. This is also probably your lung injury is due to increased permeability because of all the leakage of your neutrophils and complements from ischemic tissue somewhere else. So this ARDS which we keep talking about, your primary ARDS, is it a ischemia reperfusion syndrome? Possible. Is it sepsis? Also possible. Other peculiar thing which the physiologist noticed was, if there is a prolonged ischemia for more than say 5 hours, even if you restore the flow, RBCs don't really move into the capillaries in 50% of the time. What is happening is your endothelium swells up. Your RBCs can no longer go past this capillary. Maybe this is one of the reasons why mannitol works. Mannitol will shrink the size of your RBC, so your RBC can fold and go through the tissues. Mannitol can also probably shrink your endothelial cell size. How does fasciotomy work? Probably the same reason. When you cut the deep fascia, immediately the pressure is released, so your capillaries open up a little and some flow can happen. So most of the stuff we are doing in intensive care probably has some connection with this ischemia reperfusion model. What are the clinical effects? These are all very well described. Myocardial stunning is well described. Reperfusion arrhythmia is well described. Blood-brain barrier disruption is well described. And intensivists know all about bacterial translocation and MODS. Now what is more interesting is, by the 1990s itself, microvascular dysfunction was described with this ischemia reperfusion. At the arteriolar level, there is an endothelial dysfunction. The arterioles actually relax less and there is less blood flow. Same thing happens in the capillaries. There is a more leakage, there is more fluid filtration, and everything gets plugged up in the capillaries. And the same factors happen in the venules also. Within minutes of reperfusion, your nitric oxide level can increase, your superoxide levels can decrease, and you get a whole host of those arrows and diagrams with interleukin and tumor necrosis factor and all those stuff. And these are the diagrams that are shown in all the journals. Immediately after ischemia or with refusion, your corpuscles become more sticky. They get attached to the endothelium. Immediately the endothelium integrity goes, you get leakage, and then that vessel stops working. And these are all the diagrams. All of you are familiar with these diagrams of the various mechanisms by which the various enzymes and the cytokines can cause an IR syndrome. And very impressive diagrams of how this ischemia reperfusion causes reactive oxygen species. Now each of these slides is probably an undergraduate session on immunology and cell signaling, which most of us intensivists, we read them, but we really don't have a conceptual understanding of how all this works. And this is the cell death pathway. So the molecular biologists have got everything figured out about how cells actually die with this ischemia reperfusion syndrome. What is more interesting for us is the comorbidities of the patient. High cholesterol in the patient impairs endothelial relaxation. So if you have an ischemia, your reperfusion syndrome is going to be much higher if your cholesterol is higher. If your cholesterol is higher, the rolling of the leukocyte, the stickiness of the leukocyte increases. Your IR syndrome worsens. Same thing happens in diabetics, same thing happens in hypertensives. So the comorbids can amplify your ischemia reperfusion syndrome. Similar things happen in hepatic, and the Springle maneuver is quite interesting. You clamp the vessels and the blood supply to the liver decreases, and when you remove your clamp, you are again producing a ischemia reperfusion in the liver. And hepatic ischemic, this thing is well described. There is a peculiar thing called the pH paradox. Cell killing is accelerated by restoration of normal pH. So if the tissue is acidemic, then the cell killing is decreased. This all goes to show that too much of normal things actually produces a deleterious response. And this is interesting, the articles are full of MPTP, mitochondrial permeability pore. If this channel opens, calcium is released into the cell and the mitochondrium dies, and this is how actually cyclosporin works in transplantation immunology. It prevents this. These are the global consequences of hepatic IR. If I remove the top slide and I write sepsis, it will be true. If I remove the top sepsis and I put multi-organ dysfunction, it will also be true. The end mechanisms are reasonably similar in most of intensive care. Your hepatic ischemia reperfusion has got lung, gut, pancreas, adrenal, all these factors are there. And common consequences. Pulmonary edema is common, permeability is affected, hypoxia is there, hypercapnia is there. An interesting question. In a unilateral lung ischemia reperfusion, what happens to the other lung? You know the answer. The other lung is straight away going to get a IR syndrome, which will look like a ARDS. We'll step all this. These are the potential options to prevent hepatic ischemia reperfusion. This preconditioning, steroids and all that. Now what is ischemic preconditioning? If you expose a tissue to brief ischemia prior to prolonged ischemia, the tissue does better. Sports physiologists know this. A lot of athletes use these kind of maneuvers. This is very interesting. A turtle can dive for 6 hours, no exposure to oxygen. How does a turtle not get hypoxic ischemic encephalopathy? So somebody has gone and measured the vitamin C level in the brain of the turtle. It's very, very high. Humans have lost the ability to make vitamin C. Sepsis and ischemia reperfusion are similar, so why not try vitamin C? So this is probably one of the background theories of why vitamin C is now being used in critical care. And this is what is happening. Whether it's sepsis or shock or ischemia reperfusion, this is really what is happening in the body. Now, this is the end result of talks on sepsis, multi-organ dysfunction and ischemia reperfusion. A lot of slides are shown which both the speaker and the audience have a limited understanding on. Both of us, everybody says, yes, we know this, but we really can't go and explain it to anybody else. So how do we actually proceed? So I'm just taking 2 more minutes. So a team from Andromeda Galaxy came to my hometown in Bangalore to study vascular congestion in a major vessel. So they saw big yellow and little yellow and green corpuscles causing obstruction in the vessel. So this Andromeda Society Critical Care Medicine experts met. First suggestion was close door of yellow vehicles so that small bipeds cannot come out. Now we know that these are school buses and children are coming out. They didn't know that. Then spray chemicals so that nobody can jump out of the window. Then spray tear gas so that everybody comes out and goes into the building. This is our early antibiotic therapy. Sounds familiar? I'm giving you this drastic example because in biology, deciphering causal networks and regulatory mechanisms can take decades. So immediately giving one antibody to interleukin 6 and giving an antibody to xanthine oxidase usually doesn't work. The first 2 papers will show brilliant results. Then the Australian paper will show that there is no result. Random thoughts. Why did low MAP in sepsis show some benefit? Maybe due to ischemia reperfusion. Why did limited resuscitation, no oxygen for myocardial infection show some benefit? I think again it is ischemia reperfusion. So is IR, SIRS, rejection all waiting for some grand Newtonian theory which will come out in 15 or 20 years? So my take home message is immediate applications of sledgehammer molecular biology to complex phenomena may not work. Then after reading this topic for about 2 weeks, my take home message is keeping updated with new developments in this without conceptual understanding is not easy because this field keeps changing pretty dramatically. And my confession is, after having read all this, I don't see any difference between ischemia reperfusion and sepsis at all. Thank you.
Thank you, Dr. Sriram. That's a nice presentation. Now I request Dr. Subramani Kandasamy to talk on critical care challenges post-liver transplant.
Good afternoon, everybody. I'll try to cover this topic in 14 minutes, but don't promise. It may take slightly longer. I get permission from the chairperson at the beginning itself. We are going to talk about the post-liver transplant critical care challenges. And basically, we're going to go through what we do day in and day out when you get a liver transplant patient. So the agenda is going to be how to deal with the analgesic sedation, ventilation, oxygenation, hemodynamics, renal function, metabolic electrolyte issues, hematological issues, nutrition, infection, immunosuppression, and how do you assess graft function. The outcome will depend upon the donor factors. So the demand of organs have gone up and we now take up marginal donors. Elderly patients with comorbidities also taken up. And it also depends upon the type of donor. Obviously, the live donor will have a better outcome. In the deceased donor, you have donation after neurological death has a better outcome if the patient is managed, the donor is managed appropriately, and donation of cardiac death usually has less better outcome. And how we maintain the donors in the ICU is also very, very important. Recipient factors, the patient may have a liver transplant for an acute liver failure, they may be on dialysis, hemofiltration, or even plasmapheresis as we do nowadays. And decompensated chronic liver failure may have other comorbidities like hypertension, diabetes, they may have ascites, spontaneous bacterial peritonitis, and usually they have a very poor nutritional state. Perioperative events, the duration of operation is very important. When we started, surgery used to go on for hours and we saw the outcome was not very good, but with shorter duration of surgery, the outcome is very good. A lot of fluid shifts, especially a large amount of ascites being drained out, a lot of blood loss and blood transfusion, and also the warm ischemia and cold ischemia times which also affect the outcome. Let's move on to analgesic sedation. Before I receive my patient, I usually ready with analgesia and sedation because the nurse takes their own time to move the patient. The patient usually coughs and jumps and the blood pressure goes up. Then you give a bolus of sedation, the blood pressure drops. it's dramatic to see the amount of retraction they do during the operation, right subcostal, left subcostal, midline. So it's a Mercedes-Benz incision, and it's very surprising that they won't need much analgesia after this big operation. So sedation, I usually consider propofol or dexmed if the blood pressure is stable. I don't generally give benzodiazepines because it is associated with increased duration of ventilation, etc. But there are some liver-safe drugs, so the lorazepam, oxazepam, and temazepam. Obviously, we get lorazepam. I have not seen oxazepam and temazepam. That will be the last thing I would consider for sedation. Analgesia, fentanyl, yes, we give. The requirement is just 20 to 30 micrograms per hour. And ketamine if necessary. Paracetamol if the graft function is okay. Usually we start 1 or 2 days later. No for non-steroidals and regional blocks. Oxygenation and ventilation. Previous speakers have alluded on to all these the causes for problems with oxygenation, hepatopulmonary syndrome. Patient may have a hepatic hydrothorax, which can cause lung collapse, etc. Patient will have ascites, abdominal compartment syndrome. Post-operatively also, the patient can develop ascites or bowel obstruction, develop an abdominal bowel ileus, and develop abdominal compartment syndrome. It may be related to inadequate analgesia, they're not breathing properly, and transfusion-related lung injury is common. Fluid administration, especially give a lot of crystalloids in the presence of hypoalbuminemia, will increase the ascites and pleural effusion, if anything, and patients who are in the ICU for a longer time or in the hospital, especially acute liver failure, may have pneumonia. And as the first speaker said, there is increased incidence of thrombosis and thromboembolism in this group of patients. If this is a hepatic hydrothorax, you can see the whole lung on the is full of fluid, and the oxygen actually baseline was okay. PO2 was about 68, which improved, and then later when they during the operation, they put the chest tube, and here goes the lung collapse. And you can see that oxygenation actually dropped, and it kept on low for a very long time. It was extubated. With the tube, the lung was expanded. Once they extubated, the lung went collapsed. And this patient spent a lot of time in the ICU. This hydrothorax could have been left alone, and usually when the ascites drains and the liver graft function improves, the hydrothorax actually improves. So it need not be drained. It took a long time for the oxygenation to improve and get him off the ventilator support. Hemodynamics, usually they are in a vasodilated state, and they may have cardiomyopathy, portopulmonary hypertension, which all will affect the hemodynamics of the patient, abdominal compartment syndrome, and fluid shifts. So immediate post-op period, I'll be very worried about bleeding. So I'll watch the drains and give blood transfusion accordingly and address the hypoalbuminemia. Usually a maintenance fluid for 24-48 hours will consist of 5% albumin with a crystalloid depending upon the sodium, depending on the electrolytes, and we may give 20% albumin if they have ascites. A continuous arterial pressure monitoring is very important, and we normally go by the dynamic test for adequacy of filling, and cardiac output monitoring. Now the bedside echocardiography is available, and it's a very useful equipment. And blood pressure targets, usually we keep around 60 to 65 mean, but if they have raised ICP or if they have abdominal compartment syndrome, we'll try to target a higher blood pressure. Hypertension is very common in post-transplant patient, and we can see this even during the first week of transplant. And so this is just for all the solid organ transplants, and the etiology may be because of the calcineurin inhibitors we use and the high dose of steroids. The patients get 1 gram of methylprednisolone, and they're also put on tacrolimus, etc. very soon after the transplant. So this can contribute to hypertension, which can manifest during the first week of post-transplant period. Of course, you have to rule out pain, etc., which will also cause hypertension in the post-operative period. Renal function. It's very difficult to assess the renal function in cirrhotic patients because they produce less creatinine, and also the excretion of creatinine is higher. So when there is a compensated cirrhosis, the hemodynamics are stable, but when they become decompensated, the renal perfusion is affected and the creatinine levels can go up. And it also, because of the endotoxins, it causes systemic vasodilatation, which causes even the splanchnic vasodilatation and loss of perfusion. So there is a good, nice review of acute kidney injury after liver transplantation, and the scoring systems, and also there is another review of this where you can see how the scoring system changes. Dr. Kuttappa alluded to the international club of ascites, and they have the stage 1, stage 2, stage 3, which go by the creatinine values. They don't use the urine output values. So stage 3 is need for renal replacement therapy. So how do you assess the renal function? Creatinine may be not the best marker. You may have to use cystatin C. There is suggestion that the cystatin C and the creatinine values combined together will give a better indication of the renal function. And newer so pre-op renal failure is common, and many patients have CKD, and the cause of renal failure is multifactorial, including the hepatorenal syndrome. Patients are on diuretic for their ascitic management, abdominal compartment syndrome. Hepatitis C disease can cause glomerulonephritis and cause renal failure. There can be hemodynamic instability because of the sepsis or a lot of blood loss. And the venous cross clamp also plays a role. Nephrotoxic drugs, mainly immunosuppressants and antibiotics. Nowadays, we don't give much of nephrotoxic antibiotics. Sometimes patients have severe, extremely drug-resistant organisms, and we end up giving colistin, etc., which can cause problems in the post-operative period. So how do you monitor urine output? And you can only do an estimated GFR, and the formulas may not be accurate. And they also have a low lean body mass, so the production of creatinine will be less. Serum cystatin C can be used, and new markers like the serum NGAL can be used to diagnose early renal dysfunction. So patients may need renal support if they have hepatic encephalopathy, and can be because of renal failure. They may be fluid overloaded, metabolic acidosis, and electrolyte imbalance are the common causes for reasons for them to be on renal replacement therapy. Uremia. The renal replacement therapy may be useful in helping the removal of ammonia and other toxins, reducing the severity of the hepatic encephalopathy. And usually the choice of renal replacement therapy is going to be a CRRT, not the intermittent hemodialysis. And the choice of